In this presentation, we will be discussing the clinical manifestations for diagnosis of acute myeloid leukemia. I am your presenter, Jean Cristel Pilar. Acute myeloid leukemia is a heterogeneous group of hematologic malignancy due to genetic alteration that causes overproduction of neoplastic clonal myeloid stem cells in both bone marrow and peripheral blood. Primary oral alterations are present in 90% of AML patients. Chosen case study focuses on a 43-year-old male patient that presents to the hospital with a palatal necrosis. Physical examination revealed ecchymosis and necrosis in oral soft tissues. Laboratory findings include anemia, thrombocytopenia, elevated LDH, and serum ferritin. Diagnosis was confirmed with a peripheral blood smear and through cytogenetic studies. The patient was diagnosed with AML with the deletion of chromosome 7q. This case report review means to further discuss the topic of AML as well as verify the adequacy of the chosen case report in its topic of science. For the introduction, acute myeloid leukemia is a disease in the bone marrow caused by a disorder of hematopoietic stem cells due to a genetic alteration of blood cell precursors, and as a result, there is an overproduction of neoplastic clonal myeloid stem cells. The hematopoietic malignancies are characterized by abnormal clonal proliferation, impaired differentiation, and blocked apoptosis of myeloid hematopoietic stem cells. Abnormalities in the hematologic cellular production is largely due to the genetic alteration through chromosomal abnormalities or isolated gene mutations, without definitive causative agents. Most common mutations in the genetic coding that adversely cause AML include FLT3, NPM1, IDH2, DNMT3A, NRAS, and compound mutations. Clinical manifestations of AML generally present pancytopenia-related signs and symptoms like infections, hemorrhagic findings, anemia, and tumoral signs. Clinical studies have demonstrated the difficulty in forming a prognosis for AML because patients initially present a myriad of signs. Some cases can be discovered after performing a CBC, while others may be combined with symptomatic complications such as infections, bleeding, or disseminated intravascular diseases. First clinical manifestation may be found in the oral cavity, specifically in oral soft tissues such as the gingiva. Oral signs include the development of gingival bleeding, gingival hyperplasia, ulcers, and petechiae. Such symptoms may have similar characteristics with other systemic diseases or oral diseases. Further testing to validate the presence and severity of AML is needed. Performance of a bone marrow examination is critical for establishing the diagnosis and for further analysis of tissue to identify AML, subtype, and prognostic severity. The case of interest is focused on a patient revealed to have acute myeloid leukemia due to primary complaints of oral clinical signs. The publication of a case study focused on a rare case of AML diagnosis through palatal necrosis is beneficial to provide the foundation for similar cases in the future. Case description contains male, 43 years old, presented to the hospital with a 3-week history of palatal pain. With no other significant personal or family history for the source of disease, physical examinations revealed a painless bilateral axillary lymphadenopathy measuring 1.5 centimeters of soft consistency and pallor in the mucous membranes of the skin. While general examination showed a conscious, normotensive, and febrile patient with a Glasgow score of 15 and a fever of 39 degrees Celsius. Intraoral exam showed ecchymosis on the left hard palatal mucosa, with foci of necrosis in the maxillary left premolar region, extending from distal lingual 24 to medial lingual 26 and measuring 12 mm times 7 mm. Panoramic dental X-ray was normal, yet maxillofacial computerized tomography scan showed large osteolysis of the left maxillary bone, centered on teeth 21, 22, and 23, and the short fistula in the soft palate. Histological examination of the palate tissue revealed a nonspecific acute polymorphic inflammation of connective tissue with presence of granulation, and no sign of malignancy nor myeloid sarcoma. Infection from possible necrotizing cyalometaplasia, tuberculosis, and mucormycosis was ruled out through a microbiological culture. Initial laboratory results are as follows: normocytic normochromic anemia, leukocytosis, and thrombocytopenia. PBS revealed 60% presence of circulating blasts, C-reactive protein at 15.90 mg per L, lactate dehydrogenase at 628 IU per liter, ferritin at 1966 mg per DL, and the normal creatinine level. No abnormalities were found in serum protein, electrophoresis, and immunofixation. Biochemical and endocrine tests for liver pertained as normal. Blood cultures were negative, and infections such as human immunodeficiency virus, hepatitis panel, Epstein-Barr virus, syphilis, cytomegalovirus, and herpes simplex virus was deemed negative. Stool and urine tested negative for infectious molecular biology and cytobacteriological examination. A myelogram was also performed, revealing a very rich megakaryocytic marrow, 80% invaded by medium to large blasts, with a nucleocytoplasmic ratio of 0.8 nuclei. Observations include irregular contours, fine often nucleated chromatin pattern, granulations in the basophilic cytoplasm, and a few hour bodies. Marrow immunophenotyping confirmed the diagnosis of acute myeloid leukemia. Molecular biology ruled out the presence of nucleophosmin 1, FMS like tyrosine kinase 3 internal tandem duplications, and cytosine adenosine thymidine enhancer binding protein alpha mutations. While cytogenetic studies revealed a deletion of chromosome 7q. Given all of the aforementioned and the updated WHO classifications, a definitive diagnosis of AML with deletion of chromosome 7q was made. Treatment process included administration of sitazidime and amikacin for his febrile neutropenia, prophylaxis of fungal infections based on 400 mg per day of fluconazole, first-line induction therapy 4 cycles of the 7+3 chemotherapy protocol using continuous cytarabine at days 1 to 7 and daily anthracycline for the first 3 days, followed by complete remission and 3 consolidation cycles of cytarabine on days 1, 3, and 5. Patient was discharged after 2 weeks and scheduled for transplantation. The comprehensive case description gives an overview of the patient details, laboratory results, disease diagnosis, and the eventual treatment plan for the patient. Such a detailed narrative of the rare case can act as a flowchart for the diagnostic tests on future similar cases and may help early diagnosis. On the discussion, acute myeloid leukemia is a heterogeneous collection of sub-entities characterized by diverse pathophysiologic, clinical, cytogenetic, and molecular profiles which mandate treatment and prognosis at a case-to-case basis with each patient. In the case of the patient, multiple tests were done to assess the state of their health as well as pinpoint the cause of the symptoms. The incidence rate of AML increases with age, and as such, mortality exceeds 90% once diagnosis for individuals above 65 years of age. Most cases are undetectable in early symptoms and with only acute complications of bone marrow failure. Early identification of leukemic diseases can make a huge difference in their treatment plan. Therefore, seeing that oral cavity can present as the first clinical manifestations of disease, its recognition is imperative. After ruling out liver disease, viral infections, and molecular subset mutations, bone marrow immunophenotyping and cytogenetic studies proved to be the most useful in providing a definitive diagnosis for AML. Mutations or deletions of TP53 or the tumor suppressor gene occur in 2 to 20% of AML cases and are more common in older patients with secondary therapy-related AML and are associated with complex cytogenetics. In a study of 293 patients, 53 had TP53 mutations, which is associated with abnormalities of chromosome 17, 5, and/or 7, very much like the cytogenetics result of the case study. Treatment process consisted of the 3+7 regimen, which has been the standard of care, which resulted in long-term cures for 30 to 40% among younger AML patients and 40 to 45% of patients between the ages of 50 to 55, and 30 to 35% in AML patients aged past 60. Apart from the 3+7 regimen, other AML therapies such as the use of high-dose cytarabine combination are under strong research suggesting the effectiveness in induction consolidation regimens. As a conclusion, due to the challenges of recognizing such a wide range of clinical manifestations, cytogenetic abnormalities, and molecular mutations for the diagnosis of specific acute myeloid leukemia substitutes, comprehensive testing, laboratory result reliability, and diagnostic proficiencies are necessary in ensuring the proper standard of care for each patient that may present to the hospital suspected of AML.